All right, hi everyone. So we're going to talk, and we have like 30 minutes, I guess, but I'll try and, where'd the mouse go? There it is. I'll try and, this is more like an hour talk, but I'll try and make it functional for everyone time-wise. So anyway, we're talking a little bit about assessment of pain. I know everyone's been doing this a little bit at the different locations, but we just wanted to kind of go back over it. I'll talk a little bit about just pain pathways, some stuff about assessment. There's a million different ways to assess pain, and there's not enough time in the day to go over all those and all the validations. And so we'll talk a little bit about how you decide how you're going to assess pain. And then a little bit at the end about treating pain, particularly kind of relative to ER patients. So. Okay. There we go. All right. So the one thing to keep in mind, and this is going to come up frequently when we talk about assessing pain, is it's really a very complex experience. And we don't really think about emotional components for our patients all the time, but in general, this is kind of the internationally accepted information about pain, and it applies both to human patients and our animal patients. And that's that it's really a multidimensional experience. So there's both a sensory component and an affective or emotional component. And sometimes those are difficult to parse out in various patients. So it's not just about how the actual pain itself feels, but how it makes you feel. And so that also how it makes you feel kind of accounts for variations between species and variations within species. And those unpleasant feelings that happen with pain are kind of what we consider to be the suffering that we associate with pain. So again, it's a pretty unique personal experience, and if you take any two human patients who have the same surgical procedure, you'll have a pretty broad variation on what their perception of how painful that procedure is. And for the most part, even though we're pretty good about defining all that in people, I think almost everyone accepts now that we should assume that our patients suffer pain in a very similar way to the human experience, with all the problems that are associated with that. So pain is, again, it's unique to the individual and involves two things. One is just nociception, so the actual sensory component that's the kind of initiation of that neural processing of you touched the hot stove or someone poked you with a sharp needle. And then there's pain perception, and that's the affective component. So it's the unpleasantness of that experience, which again is pretty variable. But it's the emotional experience that is associated with that, either actual tissue damage or the potential for tissue damage. So you can imagine patients that we treat that have had multiple needle pokes, they can actually have kind of that unpleasant emotional experience prior to you even putting the needle in, just because of the potential for tissue damage. There we go. All right, so what we want to do is think about, when we're thinking about treating pain, is we kind of have to think about focusing it on the underlying cause of pain. And these aren't exclusive, so not uncommonly we have patients that have all or variations on these three things. So there's the nociceptive component, there's the inflammatory component, and there's the pathologic component. So nociceptive is the thing that we most commonly see, and that's either surgical pain, patients that have had some sort of trauma. Most recently, the example of heat would be all the campfire cats that we treated. So that's nociceptive. Inflammatory there's a gradual activation of the immune system in response to injury or infection. So again, the campfire cats kind of come to mind because they had an inflammatory component to their pain, and they also had a pathologic component because the longer that those burn injuries went on, the more we kind of ramped up some of these other changes. So pathologically, you can have basically what we consider to be maladaptive pain, and that's that kind of chronic, that kind of wind up to chronic pain scenario. And that happens because there's microanatomic changes, there's cellular and molecular changes that create this kind of ongoing sensitization of the nervous system. And again, you can have more than one type. And the other thing to keep in mind is you can have chronic pain patients that then have some sort of acute pain exacerbation that might be even unrelated to what's causing their chronic pain. So you can have, we talk about cats with acute on chronic renal failure, you can have acute on chronic pain situations. So, question, true or false? If we talk about opioids, when we talk about opioids, they have multiple effects along the pain pathway, including both peripheral and central effects on pain. Is that true or is it false? It's not a rhetorical question, by the way. How many, raise your hand, how many people think it's true? Oh, come on, just, okay, I'm not going to pay attention to you. Okay, how many people think it's false? Okay. It's true. So these are when we talk about pain, we talk about multimodal treatment. And so if you look down here, this is kind of the initial like trauma, so transductions, so peripheral nociceptors get that signal, and this is where our local anesthetics work. Anti-inflammatory drugs also work there. Local anesthetics work on these peripheral nerves, and then we have modulation at the spinal cord level. And this is where you can start to see opioids can have an effect there, as well as they can have an effect on the perception of pain. So we have modulation, we have transmission of pain going up to the brain, and then the perception of pain. So these are kind of the four things we talk about when we talk about pain treatment. We can kind of tackle treating pain at all four levels. So that's where I say opioids have more than one effect. Okay, so, one of the reasons we want to be really on top of pain in our ER patients and our surgery patients is because what we really don't want is for it to go from acute pain to becoming a chronic pain scenario. And this is something we're probably, unlike the human world where people will complain kind of ongoing after their back surgery. I mean, we don't have our patients really doing that, but they do show us signs at home with the owners that they're less interactive, less active, so they can develop chronic pain scenarios. And so why does this happen? One is there are these central inhibitory pathways, and those can be fatigued, and so they just stop working as well. So there's less of that inhibition coming down from the central from up above. And then on top of that, you can have overactivity of the ascending facilitatory pathways. So now you have less inhibition and more facilitation of that processing of pain. Some of the second order neurons and nociceptors can become hyperexcitable or hypersensitive. So what normally wouldn't trigger you to have a painful response can now become extremely painful. So if you talk to some chronic pain patients, there's certain scenarios where just something in the classic kind of situation are the people that get shingles, and then they become so hypersensitive that just touching the skin is a painful experience. And normally if you just touch your skin, it shouldn't be painful. And then actually you can have increases in the number of nociceptors. So these are all the things that cause pain to go from acute to chronic. And by treating pain, recognizing it early on and treating it in the acute phase, we can prevent this most of the time. All right. Yeah, where's the mouse is kind of sticking. There we go. So what happens if we have inadequate pain management of our patients? Aside from the acute to chronic, these are the things that are really important to keep in mind. There's, a reason, aside from comfort and having your patient not experience pain, these are things that are pretty major for painful patients. They're not going to heal and recover as well. They're probably not going to eat and drink as well, even negatively impact healing. So the campfire cats are another example of that. A lot of those cats, we did some local blocks around their ring blocks around their limbs to try and get them a little bit of pain relief so that they would eat better, because they need to eat better in order to heal. Muscle soreness and spasm is pretty common in patients that are painful because, as you can imagine, they're trying to guard that area, and so the muscles tense up, and then they start to get muscle spasm. Pressure sores, patients don't move around as much. Urine and fecal scalding. Prolonged catabolic response, again, anytime you have trauma or you do surgery, that's a big hit to the system, and those patients need more calories because they're burning more calories to heal. And if we don't treat pain adequately and they're not taking enough food and water, we're going to adversely affect that. And then you can have adverse metabolic and endocrine changes, just amplified stress response that's kind of ongoing. and that has negative effects on the immune system as well. So it can be a very kind of vicious cycle if we don't treat it. And just aside from comfort, it's really important from the standpoint of just healing, wound healing for our patients. Patients whose pain is adequately treated are going to have better wound healing and overall better kind of recovery from surgery. There's some misconceptions. Hopefully these aren't so much the case for people anymore, but I think one of the big ones in the past has been that analgesics are going to mask other physiologic indicators of patient status, or that they have too many adverse or toxic effects, especially in cats. So the classic one is that opioids are going to cause too much depression of heart rate and respiratory rate, and that's going to mask physiologic response. If you have a patient who's shocky with cardiovascular collapse, and they're also painful, giving an opioid, if you give an opiate and their blood pressure is still low, it's not because you gave the opiate, it's because they need some volume. So the drugs that we give are not necessarily negative impact depending on the type of drug. And then there's the ongoing, especially in the human world, but I think it's becoming more of an issue too with diversion of drugs, is the phobia about just opioid use in general. There's a fear of the side effects. The other thing is people think if there's no overt signs of pain, the patient's probably okay. So a patient that you don't think is painful must be okay. Another kind of misconception is that sedated patients are not painful, and that's not necessarily true, and that we can easily appreciate severity. If it's severe pain, they're going to show us, and that's also, in my experience, not true, and I think pretty well documented not to be true. So another question. You can choose A, B, C, or D. Acute surgical pain is best treated by a pure mu opioid agonist drug before surgery, non-steroidal anti-inflammatory drugs after surgery, a multimodal approach, or waiting to see how the patient responds to surgery. So how many people think it's A? Raise your hands. How about? All right. How many people think it's C?
Yes.
Yes, good. Yes. Hallelujah. All right. Yeah, I'm not asking any difficult questions here. All right, assessment of pain. That's what we're all here for today. So there's two things we have to look at: physiologic responses and behavioral responses. Physiologic responses that we fairly consistently associate with pain are autonomic reflexes, so changes in heart rate, respiratory rate, and blood pressure. Mostly those are all kind of increases in those parameters, but not always the case. Endocrine changes, those require blood sampling and measurement, but that's how a lot of these pain assessment things are validated. Unfortunately, they're not very specific and they're not very reliable. So one of the classics has been to measure catecholamines in patients and kind of assume that elevated catecholamine levels may indicate that they're painful, and use that as part of either your validation of a new drug or your validation of an assessment. They're pretty unreliable and difficult to actually measure accurately. Stress, anxiety, and fear all create similar physiologic responses, so that confounds using these just as our sole indicator of a patient's pain level. And then we have behavioral responses, and these are equally somewhat problematic because they're not all patients demonstrate equal changes in behavior in response to pain, and then there's species difference. So there's within a species there's differences, and then between species there's really big differences. And in veterinary medicine, we've been pretty good over the last few years about validating pain scoring in dogs, getting better in cats. The newer thing now is the most recent papers out are looking at a grimace score in horses to validate pain. So we're starting to cross to other species. So the other thing to keep in mind is changes in behavior don't always equal analgesia. So sometimes changes in behavior happen because of environmental issues. A patient who's already fractious interacting with people, is that change in behavior because they're now more analgesic, or maybe they're trying to hide. So what it comes down to is two things. One, you have to evaluate that kind of integrated behavioral responses. The more knowledge you have about your patient beforehand, which is tough in an ER setting, but clients kind of help you there, is helpful. And then the more experience you have. So I would say even if you, I mean, one of the best ways to get experience putting catheters in patients is to just put a lot of catheters in. One of the best ways to get experience pain scoring patients is to pain score a lot of patients. And so even if you're, if you're walking through ICU and you see various patients sitting in the cage, pull out the pain scoring sheet and just do a pain score and then pain score with someone else who's more experienced. So those are all things. It's just a lot of, the more you do it, the more comfortable you get doing it. We used to be really kind of jump on people about anthropomorphizing pain. We used to say, no, a dog is not a person, a cat is not a person. But it's actually, I think, fairly well accepted now that it's okay to assume that if it's painful to you or I, it's probably painful to our patients in the veterinary world. Although the severity may not match. And one of the good examples is, one of the best examples are, we do a lot of abdominal procedures, spays and neuters, for example, and neuters not really abdominal. We do a lot of procedures like that fairly commonly. And how many of those dogs and cats within 24 hours are up moving around, and we actually have to limit their activity. Now, if you talk to a human who's had major abdominal surgery, they are not too anxious to do much of anything for weeks. And so there's a big difference there. And that's probably a function of, dogs and cats, there's kind of that genetic background of they used to have to hide their disability in order to survive in the wild. So you have to kind of keep that in mind, that severity doesn't always match. But in general, if I cut myself and it hurts, it's probably going to be painful to the patient in front of me. Dog, cat, horse, whatever. Species-specific behaviors. Cats are not small dogs, so the pain behaviors are very different, and you'll see that on some of these scoring sheets. If the species that you're working with perceives itself to be prey, then it's more likely to hide its pain. And sometimes that can be the case, just dogs or cats that we have that have some of the more feral animals, because they're a little bit more nervous, they're more likely to hide it. So some of those patients that kind of tend to hide in the corners anyway, they're going to probably be more likely to hide their pain. Environmental factors are a big issue for our patients. A lot of dogs and cats will hide their pain in the hospital because it's an unfamiliar setting. So their kind of instincts come to play, and it's like, better hide this, better not let anyone know I'm painful. But then they get home and the owner reports back to you that, hey, Fluffy's like not eating well, seems to be kind of moping around. And we're all like, well, they weren't painful here. Well, now they get home in their more comfortable environment, and suddenly they're showing you more pain behaviors. Other thing is, a lot of times dogs, if you actually walk up and look at a dog and they're like, oh, I'm interactive, I'm going to wag my tail, they can still be painful. And so sometimes you have to kind of like do the sneak observation with them. Cats are a little less like that. Cats are usually, I don't want you to bug me anyway. Poor environmental conditions can generally worsen pain perception. So if you're, I think, and again, this is a little anthropomorphizing, but generally if you talk to people that are hospitalized, if they're in soiled bed linens, if it's not a clean environment, if it's loud, if all this other environmental input can actually make the experience worse for that patient. And I think it's true for our patients too. Okay, so some general signs of behavior. And these are, kind of a little bit broken down, dogs and cats. And I think we've probably all seen these. Facial expressions can be quite useful. So for dogs, they look like they have a headache. We see this a lot of times in the patients coming to MRI that have brain tumors, because I'm going to guess some of those have like, my head hurts because I've got this tumor. They have that kind of furrowed brow and they frown and they just look like they're not too comfortable. Cats, their ears will drop, and there's the Glasgow pain scoring thing, we'll come to that in a minute, has some nice things where you actually circle the cat's facial expression. So that's pretty useful. Cats, a lot of times if they're painful, they don't want to use the litter box. They either can't use it because of their disability, or they just won't use it because they don't want to get up and move around. How cats they'll like lay on their side and sleep, or they'll curl up. So, a cat that doesn't want to curl up and get comfortable is generally more likely to be a painful patient. Dogs that won't sit, lie down, go to sleep, you know, they're kind of standing in their cage and you can't get them to relax and lay down, and you're thinking this dog's been up for like 12 hours, it should want to lay down. Those are probably painful patients. So these are all things we can look at. Decreases in appetite, you know, general depression of attitude. But again, especially with dogs, sometimes they're just going to try and be, you know, the classic happy Labrador who's, you know, just had a major abdominal procedure and he still wants to wag his tail and come over, but then he won't lay down in his cage. So they'll wag their tail at you, but they don't want to lay down. So these are the pain scoring systems that are out there that people have used most recently. And I would say the two that are probably the best validated, but they're probably the more onerous ones to fill out are, and both of these come from the other side of the Atlantic. One is the Glasgow Short Form Composite Measure Pain Score. That's a lot. And I just call it the Glasgow score for dogs. And then in cats, there's this other one, the Multidimensional Composite Pain Scale. And that's the one that's got the little pictures of the cat faces. For a vet, I haven't actually used that one. That's another one for dogs that I think has been validated somewhat. And then there's the CSU ones. The CSU ones aren't as well validated, but they're actually pretty handy ones to use. And to be perfectly honest, I don't have some sort of personal attachment to one of these. I mean, the ones that are most validated are the ones that have come out of Great Britain. That being said, a validated pain score is of no use to you if you don't know how to use it and you're not familiar with it. So if the CSU scales are familiar and you're used to them, that's what you should use. One of the classic ones in human medicine is that, you know, on a scale of 1 to 10. And that, you know, the problem with something like that simple scaling is what's a 9 for me on that pain scale could be like a 2 for someone else or vice versa. And that's the same thing, I think, if you just use that simple type of scoring system in a dog or a cat. What I perceive a dog to be a 9, someone else might go, oh, I don't think he's. So I think having one of these scales where you have to look at multiple different parameters is much more helpful. So just looking at a patient and staying on a scale of 1 to 10, it helps, but it's not, I don't think it gives you enough information. So the things that are really important, and they come to play with all of these pain scales for the most part, are two things. One is you observe the patient without interacting with them, and then you observe them while you interact with them. So without interacting, you want to look at their posture, their movement, their facial expression, you know, what's their attitude, just sitting in the cage. And ideally, you know, if you're sitting at the desk or whatever, you can look at them a little bit afar. That's actually the best scenario because they're not interacting with you personally. And then you actually need to touch the patient. So you got to open the cage door, palpate their surgical site, palpate wherever it is that you expect them to be painful and see what their response is. And their interactive behaviors. If you open the cage door and they just, and this is the tricky one because you kind of have to flavor it with how interactive are they normally with people they don't know. But try and evaluate that. And then assign a number. And the visual analog scale is that kind of 1 to 10 thing. As long as you're kind of using several parameters, you can do a 1 to 10 scale, but you need to say, all right, I'm going to look at, I'm going to look at posture, movement, facial expressions, and each of those is going to get a 1 to 10. But that's what those CSU and Glasgow scales have done for you. The thing that's really tough is there's inter-observer variability, and that's where any one of us in the room is going to score a patient a little bit differently. So ideally, you try to have the same team member evaluate the patient. Now, that only works until there's shift change. So at shift change, if you have a patient that's been a challenging pain patient to treat, then there should be some communication about, here's how I scored this patient, and here's why I scored this patient this way. And here's what they do. When it looked like they were getting more painful, here were the things that this patient showed me on my pain scale. And when it looked like they were more comfortable, this is what they showed me. In the case of surgery patients, someone who saw the patient before surgery, so the surgery nurses are really helpful because they see the patient before it gets induced for anesthesia. So they know how that patient was before surgery, how interactive it was, Was it a calm dog, an excitable dog? All those things factor into this. And then in the case of emergency patients, owner reports, has your patient ever been hospitalized before? Has there ever had a surgical procedure? Do you know how it responds to all of that? So owners can be very helpful in that setting where you haven't ever seen the patient and it comes in with trauma. So this is the Glasgow one, and this is the short form. And we're not going to go over these, but you can just see there's various things on here that you're going to look at. And so some of these can take some time, especially the Glasgow one, but I think it's actually a really good pain scoring scale. And this one's been pretty well validated, and it's the one that people doing research on treatment of pain, this is probably one of the more common ones that gets used when you're trying to validate your new pain therapy. And then this is the feline composite score, and these are those pictures that I was talking about, and you can see you score 0 to 2. So 1 is you look at the top one is the cat's ear position, and then the bottom one is the shape of their muzzle. And those are people of, they're kind of cartoony drawings, but the more cats you look at, the more you kind of get a feel for that. Even if you're not using this excuse me, pain scale, those are kind of handy pictures to have and just put up and say, the cat on the far right with dropped ears and this kind of flattened out muzzle is the more painful cat in general. So this is the cat one. And again, you can see it's got quite a few steps to it. These are the two, the cat and the dog one for the CSU pain scales. And there's a fair bit of information to be gathered here. I don't know that the actual pictures that they have are always, to me, super helpful. I think the one from Britain is a little bit better. But again, it's really more consistently using these and getting used to them. All right. So these are the options that are really out there that have been used by most people. And I think probably a lot of clinics use the CSU ones because they're pretty easy to print up. They've got nice colors. They're relatively user friendly. Okay, things that confound it. Pre-existing diseases interfere with normal expression and pain behavior. So the example is a cat with an upper respiratory tract infection. They're gonna have a kind of funky looking face anyway. Dogs with CNS disease, sometimes it's a little hard to tell. Is their facial expression because they've got some nerve damage, or is it because they're actually painful? The big ones for post-surgery are emergence delirium and dysphoria. So from the standpoint of emergence delirium, this is generally the best way you can kind of figure this one out is a lot of times these patients won't have a very high heart rate. They won't have a very high respiratory rate, but they're clearly waking up crazy. And that's where most often I get the question, is this pain or is this patient just waking up crazy? The younger the patient, the more excited they were going asleep, the more likely they are to show you emergence delirium. The other thing is the less drug they have on board when they're waking up, so the less sedated we made them. So if we just do like a quick propofol injection and then they wake up from that, the more likely they are to have emergence delirium. And those patients, the movement they make isn't purposeful. They're clearly not interacting. You can tell they're not tracking what they're looking at, so they're not really aware of their surroundings. So usually those are pretty easy to tell. Versus the painful patient who's doing those similar behaviors, as soon as you like make a movement towards their painful site, towards their surgery site, they track that because they don't want you touching it. So those are some ways you can kind of differentiate the two. The problem with emergence delirium is you can have it in painful patients too. And so you have to try and kind of sort that out. Either way, we don't want any of our patients waking up this way, so we need to sedate them and then get a handle on where we're at with their pain control. The patient who's dysphoric, they don't like to be handled, they're vocal, they're restless. I mean, we see this with the husky that gets an opioid. Personally, my approach to this is if I feel like they need the drug for pain management, then I'm going to give them something to sedate them and take away the dysphoria, as opposed to reversing the drug. So you have to evaluate each patient individually when it comes to dysphoria. And in cats, the classic one are the cats that get Symbidol, and then the owners report, my cat is driving me crazy because he's rubbing me, he's purring, he's all over me, and he's not normally that way. That's euphoria. I actually think it's kind of entertaining when my cat does that, but it can be kind of annoying. Again, sedation will kind of really help treat that. And then there's this interesting confounder, there's observer bias. And there's data out there that suggests recent graduates of vet school, female veterinarians, are more likely to use analgesic compared to those of us who've been out of vet school for a long, long time, and male veterinarians. And there's been a couple studies done on this. I think overall that bias is reducing, but some of the more recent studies, it was kind of interesting to see that. And sometimes the observer bias can go the other way, in that if you've had if you've had a traumatic experience and a really painful experience, you're gonna be more biased towards, oh, that absolutely has to be super painful. So sometimes that can lead to someone over-treating pain. There we go. As far as, yeah. So see, we're touching his foot. And this, I think, is after we blocked Smokey. So you want to evaluate hourly for the first 4 to 6 hours after surgery. And sometimes you have to do it more frequently than that. And that would be also the patient that comes in with trauma. You want to kind of evaluate them hourly for several hours to make sure you've kind of gotten things under control. You want to not only evaluate, in the case of surgery patients, a lot of times we're tapering off of their whatever CRI they were on, so we want to evaluate the response to that taper. So you want to evaluate the response to tapering off drugs. You also want to evaluate the response to increasing treatment. So if I bump up their treatment, then I probably need to re-pain score them a little more frequently and make sure that it's doing what I want. If the patient's sleeping quietly, then it may not require reassessment until wake, but also keep in mind patients that are asleep might still be painful. A painful patient who falls asleep after you give them an analgesic is not necessarily over-medicated. They're probably like, finally. So sometimes people think, oh, I gave them this drug, now they're sleeping, I've given them too much drug. So you need to kind of sort that out and really evaluate that. And so you can evaluate them without waking them by just getting physiologic parameters. My experience is most patients who are inadequately pain controlled probably aren't going to sleep that well. More frequent and more in-depth assessment, interactive assessments, the more frequently and the more interactively you do it, and the more kind of frequently you score them, the more likely you're going to catch things. But we all are pretty busy, so that's why we try and schedule based on what the patients had done. Where'd my little arrow go? There we go. Okay, so another question. Drugs that by themselves have a multimodal analgesic effect include either which of the following, or all of the above, or none of the above. So how many people think it's I'll just say all of the above or none of the above. Yeah, it's actually all of the above. All those drugs have multimodal effects. So that's pretty handy. So this is a pretty complicated slide. This came out of a human pain management thing, but you can see, like, for example, if you look at opioids, and this one's a little more detailed than that earlier slide, but you can see like transduction, perception, descending modulation, transmission. You see opioids show up in all 4 of those locations as having an impact, which speaks to why they're so effective for us. But the other ones that show up are NMDA antagonists. So ketamine shows up as far as perception. It has an impact on local modulation. So and also transmission. This is a human paper, and they list gabapentinoids we're still kind of sorting out whether things like gabapentin are actually that effective in our patients for pain management. I think we've maybe kind of overused them without really having good knowledge. But these are just a bunch of different examples. Alpha-2 agonists, so don't forget that dexmedetomidine is a really great analgesic. This is another thing out in the human world. This is just a recommendation, and this is partly a function of that whole issue in human patients of, you know, minimizing opioid use. But what I really like is kind of their principles of pain management, and one is establishing realistic pain goals. Now, our pain goals are for our patients to be comfortable post-op or post-trauma, and we don't have this. Our patients don't report to us as much as the human. But one thing that's common in people is there's this expectation that you're going to have zero pain, and that's just never a practical, feasible scenario. Educating patient caregivers on pain management goals and regimen. So this speaks to what we tell the owners when we send the patient out the door, is educating them on you know, what are our goals, what are they supposed to work home, what's realistic, and then looking at pharmacologic and non-pharmacologic options. And then this is the biggie: continually reassess patients' pain, monitor for medication efficacy and side effects. And then the rest of this, a lot of this is kind of more based on the human scenario, but they have this ladder where you start out at, you know, mild pain is going to be things like using an NSAID, versus moderate pain, maybe they might intermittently dose an opioid, versus severe pain where they get a little bit more aggressive. So we can do the same thing when we're looking at pain medication. All right, so this is the tricky part about ER patients, and we're not going to spend a lot of time on this, but what's important to keep in mind is the things that show us a patient, that show up in painful patients, also show up in circulatory shock. And so sympathetic stimulation, vasospasm, hypoxemia, ischemia, decreased GI motility, all these things can be either shock or pain or both. And that's what makes it tricky when we talk about the ER setting. In general, I just want to reemphasize this. If your analgesic drugs cause your patient to have worsened cardiovascular status, then it's likely the patient has cardiovascular compromise that needs treatment. It's not that you overdose them on your pain medication. All right, so if it's an ER patient and that's what you're seeing when you give a dose of, say, hydromorphone, they suddenly cardiovascularly are worse, then you need to evaluate what their circulatory status is relative to what they're presenting to you for. But as we talked about, and this is true in the ER too, you want to use a multimodal approach. And obviously opioids are one of the big go-tos that we have. One of the things that we find is that people reach for the partial agonist or agonist antagonist, and those are significantly less helpful as far as treating trauma pain or patients that are headed to surgery, and they really confound the treatment of the patient in surgery. So if a dog gets a dose of buprenorphine, that's absolutely tied our hands from when it's going to go through the door into surgery, and it's tied our hands for 4 to 6 hours. So just keep that in mind when you're thinking about what am I going to give this patient that might go to surgery. Local anesthetics. I don't know that we think about these as much as we probably could in ER, but obviously for laceration repairs, we've done a couple patients that have had rib fractures where we've done intercostal blocks. And if the patient's going to be hanging out with us for a while, for those intercostal blocks, you can think about using Nocita because you get a longer duration of effect. So I can't remember the name of the dog, but the one that had like almost flail chest a while back that we did Nocita intercostal blocks, and that dog was definitely, we did Nocita on the burn cat, the campfire cats, and they were definitely more comfortable. And it just means I got to poke them less frequently with the needle. So think about that. And regional limb blocks, those are pretty rare that we would do those, but if we need to palliate a patient that is not stable to go to surgery for some sort of fracture, we could consider doing a regional block. People certainly do it. Ring blocks for distal injuries are really easy to do. Low dose ketamine, NMDA research. So Low-dose ketamine is a pretty useful adjunct for analgesia. And we're using a lot in surgery because of the opioid shortage. But I think it's helpful anyway. If your patient is otherwise healthy and stable, you can use microdoses of alpha-2 agonists, and you can add in an NSAID. But these need to be cardiovascularly stable patients that are okay to have those drugs at that time. If the patient is headed for surgery, it's preferable not to give the NSAID until they come out of surgery because of the potential for hypotension and damage to the kidneys. So these are the things to consider. And I'd say the biggest thing is just be aware of, what's kind of the long-term, what's not just your short-term goal, but also where's this patient headed in the next 2, 3, 4, 5 hours? Are they just going to hang out in CCU and recover from whatever trauma they had, or are they going to go into the surgery suite right away? Because that flavors what you're going to use. And so that's a good time to talk to the surgery team and say, hey, what do you think you're going to need this patient to be on, so that it helps us move forward that way. Okay. Pain score your patient on presentation if you can, because you want to know where you're starting before you give these drugs. And then giving the analgesics at regular intervals, pain scoring immediately before and after. Ideally, you don't want to wait until your patient is painful, because that's going to ramp it up and you're going to need more analgesic drug to overcome it. So if you have something, remember that anthropomorphizing. I think if I had a broken leg, that I'd probably be painful for more than just a couple hours. And so I'm going to want regular doses of morphine. And so think about that patient. Obviously, pain score them right before you give the drug, but don't let them become painful just because you want to make sure you're not over treating them. Think about what you're treating and kind of have a plan there. So you want to choose an analgesic plan according to the intensity of pain and anticipate ongoing pain. So you need an adaptable plan too. And obviously you've seen us have to change plans based on patient response. Have a goal in mind for what you want to accomplish, and make sure, and as best you can, try and do a multimodal plan. But don't just throw drugs at the problem. Really think about how those drugs work and how they're going to impact your patient care. And for example, is ketamine going to help me? Is that using that NMDA pathway going to help me better control this patient's pain? Probably in a lot of patients, but in other patients, maybe that's not the drug I want to use. Maybe an alpha-2 agonist is going to be the choice in this patient because it's otherwise a stable patient. So really try and plan out. Don't just automatically reach for the bottle of hydromorphone every time. Really think about what am I treating, what I'm trying to accomplish, what's my long-term plan. And fit the plan to the patient, not the patient. Some clinics have like, this is what we do for everything that has a laceration. Well, that is it's helpful one way, and another way it's also doesn't work for every single patient. So kind of think about that. Okay, that's like a breeze through. Hopefully it was helpful. Any questions? Or did I put you all to sleep? Post-lunch food coma. So I think the biggest thing is talk to people who are experienced doing pain assessment and really kind of work together as a team. Just, up your skill set there and get comfortable with it, because it's really, the more you do it, the easier it's going to be. All right.
Thank you.
Thanks, guys.